Good morning. I'd like to welcome you all to Grand Rounds on this cold day outside. We've got a very exciting, interesting topic by two of our esteemed nephrology faculty, Dr. Hix and Dr. Hsu. I'd like to welcome them all. I want to say that this institution with the nephrology group and has really played a major role in the in figuring out the basis of calciphylaxis and the future of treatment. So I'll yield the floor to Dr. Hix and Dr. Hsu. Thank you.
Thank you all for coming. It's really an honor to speak here. Yes, our disclosures, we don't have any financial interest in anything that we discuss here, but there's also, everything is pretty much off-label. There's no really good therapies, and just what we're talking about is a lot of theory, but not a lot of good evidence. I'm going to talk myself about the scenario and some of the terminology and history, and then some pathophysiology, with an attention to areas of what I'll call clinical responsibility, at least things that we should consider ourselves to get involved with this disorder. And then I'll yield to Dr. Hsu for diagnosis and treatment. The scenario is one that you probably all see quite often. It's an elderly man who is not diabetic, was admitted for a fall and a fracture. And he does have a history of alcoholism. He's on a warfarin because of a history of atrial fibrillation. He had mild chronic kidney disease, and he had obesity. When he was admitted for the fracture, he had x-rays, and I'm not going to look at the bones so much as everything that's not bone here. You can see he has calcified blood vessels in the leg, as well as some calcifications of the soft tissue, and he has plenty of adipose tissue. Later on, a CT scan done for unrelated reasons shows even calcified blood vessels in the adipose tissue in his pannus. He is in the midst of a long hospitalization. He has some sort of fall and develops a very large, firm, very painful mass in his abdomen. It was thought to be a hematoma, but it extended into the surrounding tissue and began to ulcerate, progressed, and ultimately required a wide local excision. This is the area post-excision, and after frequent and expert debridement and excellent attention to infection and infection control. Several weeks later, over time, he's still having poor healing, and severe pain of the lesion is persisting. And then there's the development of ominous new areas, more painful lesions that are still palpable subcutaneous and began to change in color the overlying skin. So as you may have guessed, he did not have hematoma. And in fact, the pathology, and I have a special thanks to Dr. Yi and pathology for going through this with me, did not show hematoma, but raised a question of calciphylaxis. What they saw was calcification of small arteries, and then the occlusion of arteries, with the intimal layer becoming fibrotic and narrowing the lumen of the arteries that it surrounded. You can see in the stains obvious calcification of small arteries, and areas of fibrin thrombi and necrosis in the fat and in the septae in between the adipose tissue. And you get this picture that, this word is worth keeping in mind, this reticulated necrosis, a sort of honeycombed area of necrosis around the adipose tissue that was visible in the biopsy. And so what is calciphylaxis, or where does it come from? And calciphylaxis is a term coined by Dr. Selye in 1961, and he was a remarkable sort of researcher. And this calciphylaxis term is a conjoining of calcification and phylaxis. And this was an experimental model that he had in the lab. And in the modern clinical era, there's been a turn towards a more descriptive name called calcific uremic arteriopathy. But we are going to use the term calciphylaxis primarily. Selye's model was an experimental condition. And what he proposed is that you have an animal and you sensitize it with something like vitamin D or parathyroid hormone extracts. And then you give that animal a challenge, for instance, an injection of iron dextrin. And in the sensitized animal, you get this acute and dramatic cutaneous calcinosis in these areas where the challenger was applied. But oftentimes, this in the model would be effervescent. It would be dramatic, it would be rapid, and then sometimes it would heal. Hans Selye went on to become very famous in his work on the stress and the stress model and how it impacts illness. And he had this quote that I liked. It said, "Every stress leaves an indelible scar. The organism pays for its survival by becoming a little bit older." The question about calciphylaxis is what is this process protecting us against? And I think that's, or what could it be protecting the organism against? And I think that's not clear. He did have one model of progeria in a mouse, and giving the mouse calciphylaxis would actually protect the animal against the effects of progeria. So there may be some underlying physiologic mechanism. What he postulated was that calciphylaxis was a biological way for an organism to move calcium away from vulnerable organs and into other areas where the animal could survive better if the calcium was either deposited or stored there. Not long after his descriptions, in 1969, there was an article that suggested that calciphylaxis did occur in man. And this was a 21-year-old who was being treated with glomerulonephritis. And he was getting anabolic steroids and prednisone. He was very anemic. He had near end-stage renal disease, and they were giving him iron injections into his thigh. He developed extremely painful lesions in the thigh. And on x-ray, you can see that there's extensive calcification right where they were injecting iron to treat the anemia. Biopsy of these plaques confirmed that there was extensive calcification in his subcutaneous tissue. And so this began to be more and more reported, associated with renal failure patients. And oftentimes, these calcifications looked a lot like what the model for calciphylaxis did, at least superficially and pathologically. And the thought was that just like in the model Selye had, maybe the hyperparathyroidism of chronic kidney disease served as a sensitizer, and maybe metal or injections or trauma or something else would then be the challenger that allowed the calciphylaxis process to get started. And that was a working theory for a while, but it turned out not to be so simple. And this is kind of a good place to bring in the Rochester General Hospital connection to this story. Sagar Nikwekar was a resident here, and he subsequently became chief resident and was a hospitalist for a while, and now is continuing his career at the Brigham and Women's. When he was a resident, he actually was on the consult service and had a case that he thought might be calciphylaxis, but the patient did not have chronic kidney disease. And it turns out that the diagnosis in that case was very supportive of calciphylaxis, and he started looking into the concept of calciphylaxis from non-uremic causes. He went on to compile a case series from the literature and his own experience of 36 cases. And I just want to say that he has since become probably, and I would say arguably, the world or one of the world's experts in calciphylaxis, starting from the origin of his interest in this case when he was on the consult service here at Rochester General Hospital. He published the cases of 36 cases of non-uremic calciphylaxis in what has become one of the most widely cited papers in this literature. You'll see some overlap in the causes that he postulated or that he recorded in these case reports with our patient: alcoholic liver disease, significant weight loss, and some chronic kidney disease, but not end-stage disease. In the scenario that we're talking about matched fairly commonly with some of the scenarios that he was able to outline in these reports. The patient had relatively mild elevation in calcium, a normal phosphorus, normal parathyroid hormone, and a creatinine that was not normal, but was certainly mild to moderate chronic kidney disease. But he was on warfarin, and 25% of the patients in this case series were also on warfarin. And so that becomes sort of a theme behind some of where the thought process of this human condition has gone. The histology in these cases has overlap with the histology that you see in the calcinosis of Selye's model, but the prognosis is much different. In the human condition, the mortality is horrific. And there are reports of both high mortality in absolute as well as relative to the already high mortality of end-stage renal disease. So while there's some similarity to the experimental model, it seems to be that there's vast differences in the human condition as well. So what is happening in the human condition? What's happening here? And we don't know, but there is maybe some value, at least, in taking a sort of a heuristic approach and looking at those things that are at least similar in these cases and maybe similar in the experimental model. It doesn't sound very enticing to begin with, but I want to express that if you've not seen this condition, it really is like a distillation of human suffering into one disorder. It's incredibly painful. We don't know what it is. We don't know how to treat it. It progresses and it often kills patients. And Dr. Hsu will expand upon this, but we really cannot sit back and rest on the idea that we don't know what's happening. We have to at least look in areas that we could possibly intervene. So 3 areas I'm going to at least touch on, and these are not comprehensive by any means, would be the location and the involvement maybe of adipose tissue and blood vessels contained within, the concept of mineralization, and maybe, I won't get into thrombosis, but at least mineralization at trauma sites, and then the overlap in those cases that Sagar outlined that had background history that makes you at least think of malnutrition and vitamin K, and we'll see that role in this as well. Big caveat, what follows is mostly just hypothesis in the most vague sense. I'm going to try to tell you a not unlikely tale as to what might be happening. I'll start off with a very astute observation in Australia, and I'm not a surgeon, but they raised the question as they went through debriding these cases as to whether obesity played a role in calciphylaxis. And I'm told that in some of these situations when you do surgery on patients with significant obesity, there's almost like a fasciotomy appearance when you open up the skin, that the adipose tissue is clearly under pressure and sort of comes out. And they raised the question as to whether the stretch of adipose tissue and the physical forces played a role in calciphylaxis. Just to go over the anatomy and vascular supply, in adipose tissue, you have these lobules of subcutaneous fat. And it's not just sort of like a big blob. They're sort of separated by these fibrous septum. And within the fibrous septum are blood supply and vascular supply and smooth muscle cells and innervation. And you look at that, and it's kind of got that reticular appearance to it. And this is what they saw when they excised tissue. They would see these strands of these septi, and they were elongated and distorted, and they looked like they were stretched. And those were the areas where the calcification of these patients was predominant. And the surgeons proposed that this chronic tension on these subcutaneous septa imposed by large amounts of adipose tissue may localize calcifying activity of serum factors. And that doesn't seem so crazy to me because in nephrology we have a model of pathologic bio-mineralization in the formation of kidney stones. And there's at least one working theory that kidney stones may arise from people who don't drink enough, have sluggish urine flow in the setting of a high urine calcium. And that sluggish urine flow may transmit pressure to the deep descending parts of the nephron. And inside that calcium, that milieu of excess calcium, that parasites associated with vascular smooth muscle cells may sense this physical stiffening. And in sensing this stiffening, they may start to differentiate and generate factors that may set the stage for mineralization. So that's in the kidney. Getting back to adipose tissue, there was a study done that looked at this. They were looking at adipose-derived stem cells. Now, you read the authors, they're not sure that there aren't parasites in this as well. It's a stem cell culture derived from adipose tissue. And they did a very simple experiment. They cultured the cells and they put them on a surface that they then loaded with tension. So they stretched the cells. And they did this sort of cyclically stretching and not stretching. And if you just grow adipose-derived stem cells without that tension, they just grow haphazardly. But if you apply this tensile stretch to them, they immediately line up in an orientation perpendicular to the direction of the stretch. It's interesting, but probably more interesting than that is as they do this, they start to be able to measure bone morphogenic protein 2 and a protein called runt-related transcription factor 2. And those are both increased in these cells as they're undergoing cyclic stretch and not in the cells that are cultured without the stretch. And both of those end up being important mediators in calcification of at least large and mid-sized vessels in atherosclerosis. And of course, we're talking in calciphylaxis really about small and maybe mid-sized arteries. But at least there's some suggestion that maybe this tensile stretch has the possibility of upregulating proteins that are involved in calcification and atherosclerosis. To really make that more exciting, you would have to demonstrate that bone morphogenic protein is present in non-uremic calciphylaxis. And Sagar's group actually did this. These are biopsies from patients with non-uremic calciphylaxis. And you see the stain for calcium in the blood vessels, but they also stained for an effector protein, SMAD. And that protein is an effector protein from bone morphogenic protein receptors. So in a sense, you're able to demonstrate the effect of bone morphogenic protein right in the lesion of calciphylaxis. So that's at least very interesting conceptually. This also puts bone morphogenic protein in those areas of the septum where we know that there are vascular smooth muscle cells, because that's where the vasculature that supplies the adipose tissue lives. And there's a widely accepted sort of schema for how contractile vascular smooth muscle cells may develop and may, in a sense, change into cells that are osteochondrocytic smooth muscle cells. And this is a complicated process, and rather than getting sort of lost in that, I just wanted to highlight one thing from this schema, which is that these cells are under all sorts of stress all the time. And so that we have physiologic processes that prevent vascular smooth muscle cells from differentiating into cells that can cause calcification. So you have all these regulators that prevent that from happening. And one of these is MGP, which is matrix GLA protein. And matrix GLA protein starts to take the stage here in calciphylaxis because it is a protein that inhibits calcification. If you have mice in which you have knockout of matrix GLA protein, they have arterial calcification develop within the first 4 weeks of life. But matrix GLA protein is inactive unless it's carboxylated, and it requires carboxylation to function normally as an inhibitor. And that carboxylation is dependent upon vitamin K. Without vitamin K, it's not carboxylated. Without carboxylation, it doesn't work. If it doesn't work, calcification occurs, at least in animal models. So the question arises as to how does this happen, and is there any influence in our treatment on patients? And this is a series of very elegant experiments done by Reynolds. What he did is he cultured vascular smooth muscle cells, and he cultured them in 2 different ways. He used regular media that he would then increase the calcium and the phosphorus within the media, giving sort of, for lack of a better phrase, sort of a uremic milieu. And then he would use the same media with serum added. So first, he looked at just controls with no added calcium and phosphorus. And the vascular smooth muscle cells just looked like normal contractile vascular smooth muscle cells. If you then culture them in media with high calcium and phosphorus, but no serum, within 24 hours, the vascular smooth muscle cells begin to be associated with a calcified granular pattern. So what looks like calcification begins to happen within a day in a media that has high calcium and high phosphorus, but no serum. The same procedure, but you add serum to the media, and 10 days later, there's no calcification except for these little punctated areas, these little tiny areas of calcification, but otherwise the vascular smooth muscle cells do not show this calcification effect. So to summarize a lot of his experiments, vascular smooth muscle cells calcify in a high calcium, high phosphorus milieu, and serum dramatically reduces that. When you look at what's actually happening as this process occurs, the vascular smooth muscle cells in the phosphorus and calcium-rich media begin to release these microscopic vesicles. And the vesicles are visible within 30 minutes of touching the media. And after 22 hours, those vesicles have coalesced on top of and around the cells in the matrix, and they form this granular deposit. If you look at the vesicles themselves look like they're calcified, and they're present within and on the surface of the vesicles are what looks like calcium phosphorus deposition. And indeed, if you actually X-ray it, there's peaks at calcium and phosphorus. So it looks very much like this is calcification happening on and within these vesicles. There are two sizes of vesicles, and this is a little bit in the weeds, but somewhat important because there are matrix vesicles which seem to come from viable smooth muscle cells. And there are also apoptotic bodies which seem to be derived from smooth muscle cells that are undergoing apoptosis. So both viable and apoptotic smooth muscle cells are contributing to the release of these vesicles. If you stain the vascular smooth muscle cells for viability, you can see that within this calcifying process, the vascular smooth muscle cells, at least many of them, remain viable. So they're alive and actively contributing to the calcification. And then if you measure that calcium incorporation into those vesicles in the presence or absence of serum, when you do this in the presence of serum, there's much less calcification. So it suggests there's something in serum that inhibits calcification. When you analyze by Western blot the vesicles themselves, they're loaded with matrix GLA protein. Okay, so that's within the vessels, and it clearly seems to inhibit calcification of those vessels and the process of calcifying the matrix. What's really interesting is that if you pre-treat vascular smooth muscle cells with warfarin, you have no effect on how many vesicles they release in the medium, but you have a threefold increase in calcification after pre-treatment with warfarin. And the effect of warfarin is most pronounced in the situation where the calcium and the phosphorus environment go up. So if you culture the cells in a low phosphorus environment, there's low calcification of the vesicles, and there's no effect of warfarin. As the phosphorus begins to rise in the media, the effect of warfarin becomes much more dramatic. Vesicles don't calcify in the absence of warfarin, and they calcify much more dramatically when you pre-treat them with warfarin. So you at least have some idea that this calcification process depends, at least in part, on the matrix GLA protein. A healthy matrix GLA protein seems to inhibit calcification in these vesicles, even in an environment that we would consider high calcium and high phosphorus. And if you have what you would consider dysfunctional matrix GLA protein, probably from not carboxylating it, then the calcification becomes much more dramatic. So at least in our chronic kidney disease patients, and probably in patients who have cancer, alcoholism, and other causes that associate with or cause malnutrition, what do we do? Well, at least in CKD patients, we tell them to have a very low potassium and a very low phosphorus diet. And by default, those things cause patients to have a low vitamin K intake. And in fact, if you look at vitamin K deficiency, both in vitro and in vivo studies show that vitamin K antagonists induce vascular vitamin K deficiency in vascular smooth muscle cells. And those animals treated with a low vitamin K diet become atherosclerotic. And there are studies of chronic kidney disease patients that suggest a low vitamin K status. And vitamin K supplements may improve this. Sagar's group took this idea one step further and looked at actual carboxylation of matrix GLA protein in patients with calciphylaxis. And what they were able to find is that both in cases of patients who were on Coumadin as well as patients who were not on Coumadin, if you had calciphylaxis, you were most likely vitamin K deficient, or at least much more likely to be vitamin K deficient. So again, you have an association of vitamin K deficiency in our disease of interest in the patients who are susceptible to this disease of interest, and at least some pathologic mechanism that may tie vitamin K deficiency into a causative mechanism for calcification. So to try to go through what I've tried to at least present, the tale I've tried to tell, is that in the normal state we have contractile smooth muscle cells, and they maintain the tone of blood vessels. As part of that, they synthesize matrix GLA protein, and that actively inhibits mineralization. But that matrix GLA protein is dependent upon vitamin K to carboxylate it, and that carboxylated protein is what actually inhibits mineralization. If you put these cells in a high phosphorus, high calcium oxidative milieu, and chronic kidney disease is a common cause of that, but there may be other causes that increase oxidative stress or even physical tensile stress, then they still synthesize matrix GLA protein to inhibit mineralization, but some of those cells begin to change. And they begin to sort of transform into these synthetic or proliferative vascular smooth muscle cells. They lose their contractile property, and they start to synthesize things. They synthesize matrix GLA protein to inhibit calcification, but they also begin to encounter or synthesize or come in proximity to other effectors like bone morphogenic protein. Now, there's an interplay there. The carboxylated matrix GLA protein will inhibit bone morphogenic protein. But if you culture these cells, or at least look at patients who have a high phosphorus, high calcium, or oxidative milieu with low vitamin K, then vitamin K depletion can occur. Without vitamin K, matrix GLA protein does not get carboxylated, and you lose the inhibition on bone morphogenic protein. And that can then start to have feedback on the vascular smooth muscle cells themselves. That can cause them to further differentiate into these osteochondrogenic vascular smooth muscle cells, which begin to then lay the framework for mineralization on themselves and in the matrix surrounding them. They also produce less matrix GLA protein, and they begin to undergo apoptosis. And as we saw, these vesicles and even the apoptotic bodies they release can be effectors in mineralization. So I try to get some background as to what I think is some of the pathophysiology. And now Dr. Hsu talk about diagnosis and treatment. Thank you.
Thank you, Dr. Hix. And let's go on and talk about some of the diagnosis and treatment and some of the options that we have out there. A good portion of this talk is going to be focused on some of the challenges, in fact, we have with this, because there is actually very little data or good data on both the diagnosis and the treatment. We'll go over some of the options that we have out there, and also some of the therapies that we can try, both now and also some things that have been done historically in the past. We'll also touch base on some of the future directions or things on the horizon that are potentially coming. Well, the problem with diagnosis is that still there is no actual formally accepted diagnostic criteria, and we're left with many puzzle pieces and oftentimes looking at a patient and not knowing what to do. Part of the problem with diagnosis also is that historically this has been a very rare disease. Okay? But the reality is that maybe it's not so rare. In fact, the incidence of this is felt to be increasing. In the end-stage renal population, some current estimates are in the neighborhood of 1 to 4.5% of the population. Let's talk about the clinical presentation, some of the lab tests that we could try to utilize, imaging, and the potential role for biopsy as well. So in the clinical presentation, most of the times this does affect end-stage renal patients, but also advanced CKD. Now the hallmark of this is that the patients will pretty much always present with extremely painful lesions. These are described as subcutaneous nodules or plaques. In the more advanced cases, you'll see areas of ulceration and necrosis. But again, one of the hallmark features, again, is extreme pain. As far as the distribution, it does tend to be in the areas of greatest adiposity. So in the torso, in the buttocks, the thighs are a very common area, breast tissue. Now, it can also appear more distally in the acral regions, the fingers, toes, penis. The distribution actually is important as well because it does have implications in terms of prognosis, with the distal lesions generally having a better prognosis, although still a poor prognosis. This was a series of the calciphylaxis patients at Mayo Clinic over a 15-year period. They had approximately 100 patients, and these were just some of the baseline characteristics that they were able to identify. There's a couple that I would like to highlight. We can see that most of the cases were female, about 80%. As far as dialysis, I was a little bit surprised that they only had about 60% of their patients were dialysis patients, which is actually a little bit less than is quoted in some of the other literature. If we do combine that with stage 4 disease, stage 5 non-dialysis patients, and end-stage renal patients, we get closer to about 75% of their population. As Dr. Hix mentioned, obesity is also more prevalent. Diabetes, about 50% of their patients, or 54%. An interesting point about diabetes is that it is not clear whether or not good glucose control makes any difference in the incidence of calciphylaxis. It's merely the presence of diabetes. Again, disorders of mineral bone disease, hyperparathyroidism, hyperphosphatemia, hypercalcemia. And in their series, they saw that 63% of their patients were on warfarin at some point. Now, this was a review article just published last year by Dr. Neguekar in the New England Journal. It's a very good review article. If any of you are interested in looking more at this, I encourage you to read it. But he summarized, again, some of the identified risk factors. Many of the things are similar to the previous slide as well, but we see that there are some other incidences, thrombotic disorders, even things like rapid weight loss have been implicated, some interesting scenarios. So if someone presents to you, they're an end-stage renal patient, they have horrifically painful ulcers, then perhaps the diagnosis is not so difficult. But the problem is that's the minority of the cases. So about 80% of patients will actually present with plaques. Again, these are painful plaques, but only about 20% of the people will actually have ulceration at presentation. And in fact, this paper describes one such patient who presented with, it's a little bit hard to see here, but areas of erythema. There is a border there. It was initially felt to be cellulitis, pretty reasonable diagnosis to make. Unfortunately, this patient, 3 months later, looked like this because they developed full-blown calciphylaxis, necrosis. This patient did undergo skin debridement, but we can see that there's obviously a quite significant progression here. When we look at the presentation, whether or not someone has ulcers or not does have a significant impact in terms of their prognosis. This slide shows that for patients who had plaques only, at the top on the 6-month, we see they had about a 33% 6-month mortality. But if they presented with ulcerations, that 6-month mortality was 67%. Over time, if any of these patients went on to develop future ulcerations, their 6-month mortality was upwards of 80%. Now, this is just one case series, but it is fairly consistent with much of the other literature, quoting approximately 50 to 60% 6-month mortality for calciphylaxis. We already know that for the end-stage renal patients in general have a higher mortality compared to the general population. But when we look at an end-stage patient who also has calciphylaxis, their mortality is 3 times that of a typical end-stage patient. So looking at the patient, we have to keep in mind, well, what is our differential diagnosis? I'd like to touch base on perhaps the first one, warfarin. We've talked about that quite a bit already. So we know that there is an increased incidence of warfarin use in patients with calciphylaxis. How do we know that this isn't perhaps warfarin-induced skin necrosis? It can be difficult, but probably one of the helpful things here is going to be the timing. With warfarin-induced skin necrosis does tend to be earlier on when people first start anticoagulation, whereas in calciphylaxis patients, these patients have generally been on warfarin for many, many months. What about lab tests? Well, again, unfortunately, there is no specific lab test that is really going to nail down this diagnosis. We've talked about the chronic kidney disease aspect, so knowing the renal function, knowing the mineral bone disease parameters. When we're doing the lab investigations, it's really based upon essentially what your differential diagnosis is. So this list is certainly not meant to be comprehensive, and these are merely recommendations, but things that you might consider when looking at patients who are presenting with such lesions. What about imaging? I know I myself have recommended checking imaging on patients with suspected calciphylaxis. Well, what is the evidence? Well, this is a patient who had calciphylaxis of the thigh. We see there's areas of net-like microvascular calcifications. We also see extravascular calcifications, and we see quite a calcific femoral artery here as well. Mammography is often cited in the literature. This is calciphylaxis of the breast with areas of fat necrosis and these linear areas of microvascular calcifications as well. Now, what's interesting about mammography is that mammography is actually not just for breast tissue. So in fact, this is a gentleman who has calciphylaxis of the calf. And the corresponding image is a mammographic image of the same area. And we see that there's quite extensive calcification noted on that image as well. Now, I personally have not tried to order a mammogram of the leg at this institution. I'm not quite sure if that's something that we can do or not. This slide is a summary of a case series of 7 patients who were felt to have calciphylaxis based on pathology or skin biopsy specimens. There's a lot of information here, but the main point of the slide is to show that whether it's a mammogram or a plain film X-ray, CT, they can actually pick up areas of calcification that are really very small, down to 0.1 to 0.3 millimeters in diameter. Bone scan is something that is often done as well. The figures on the left is a patient who had clinical diagnosis of calciphylaxis and underwent a technetium-99 scan. We see areas of increased uptake in the corresponding areas of clinical calciphylaxis that this patient had under the arms, in the pelvic region, in the side. I believe this black area in the bottom is a Foley catheter. The series of images on the right is a different patient, but it's a very interesting image because it shows that the first 2 pictures, or the middle 2 pictures, I should say, this patient also had clinical calciphylaxis, and we see areas of increased uptake in the corresponding areas. But this patient also underwent aggressive treatment for calciphylaxis and did have clinical resolution of their lesions. They had a repeat bone scan done after that, and we see that the areas of increased uptake have dramatically improved. Now, bone scan is felt to be helpful more so earlier on in the course of disease, when patients are already progressed to the point of having ulceration and necrosis, then that tissue is already essentially non-viable and dead, so it won't have a significant uptake. This was a series of 18 patients, again done out of the Mass General, looking at bone scans, and they saw that of these 18 patients, 16 of them had positive bone scans. The interesting point is that they actually took 31 controls, their controls being patients who actually had end-stage renal disease as well, but did not have a clinical diagnosis of calciphylaxis, and only one of the 31 had a positive bone scan. Well, biopsy. It's considered the gold standard for numerous diseases. Why not calciphylaxis? Well, again, it's still not clear here. I'll go into the reasons for that, but when it is done, we just want to make sure it's done by someone who has quite experienced hands. It is a 4 to 5 millimeter sample, a punch biopsy, or a telescoping biopsy, which is basically a punch within a punch. And we want to make sure that we avoid areas that are, frankly, necrotic or infected areas, or the fingers and toes and genitalia. So why wouldn't we do it? Well, this disease is already so painful to begin with that we might just inflict more pain on the patient. And there is some concern that adding this additional trauma to the area, you will actually propagate new lesions, propagate ulceration, further necrosis, further complication. The other problem is that even though we do use biopsy a fair amount, and in fact in the literature it's often reported as the gold standard diagnosis, there's still no definitive criteria for it. So we generally will see in the small arteries and the arterioles calcification, microthrombosis, fibrointimal hyperplasia, but all of these findings really are nonspecific. So this group tried to answer this question and see, well, how helpful are these histologic criteria? They took 38 patients who were suspected of having calciphylaxis and did skin biopsies on all of them. And then they took 37 patients with end-stage renal disease who did not have any suspicion of calciphylaxis, but they were undergoing amputation for other reasons. And they did a pathologic examination of the amputations. Again, they were looking at the three criteria that are generally described for calciphylaxis: the calcification, thrombosis, hyperplasia. And what they saw was that the only finding that really had any difference or statistical significance was a thrombosis. But we see that it's still not the most impressive result. 36% of the skin biopsies of patients with suspected calciphylaxis showed thrombosis. And even in the amputations, even if there's no suspicion of calciphylaxis and no clinical diagnosis of calciphylaxis, still 14% of them can have thrombosis, so a very nonspecific finding. Now, if they actually took their patients who they really felt had calciphylaxis, the patients with a high index of suspicion, and then looked at those patients specifically, we do see there's a little bit better separation of calcification. There's a threefold increase. Thrombosis, also a threefold increase. But if we look at the combination of the two, of having both calcification and thrombosis, then we do see a sixfold increase. This data is a little bit, I would say, moderately helpful, though, because, again, if you're looking at patients who have a high suspicion of calciphylaxis to begin with, then I think you've already gone a fair amount in terms of establishing a diagnosis. We still don't really know if a skin biopsy is really necessary. Okay. Now, this same group in the Mayo Clinic, which I described before, they actually came up with their own diagnostic criteria in their study. It is not generally a widely accepted criteria. The reason why I'm really showing it is that they're showing that they have skin biopsy criteria on the left column and clinical criteria at the top. And the point being that a patient can have no skin biopsy done at all, and just based on clinical criteria, if we look at the bottom line, we see they can still fit in the definite or probable diagnoses of calciphylaxis. So again, a skin biopsy is not essential, in their view, to make this diagnosis. So with all this difficulty, a lot of this goes to expert opinion. And this is actually a survey of a group of experts. So this is 13 13 physicians considered world leaders in calciphylaxis. They were brought together, and it's interesting. The article says they engaged in a, quote, vigorous discussion. And after this vigorous discussion, they were all given a survey to answer anonymously of 20 questions. And they were, each question could be rated 1 through 9 in terms of how much they agreed or disagreed. So what did the experts think? Well, the one on the left is, how important or is a skin biopsy a prerequisite for diagnosing calciphylaxis? And we see that it's pretty much across the board, almost random, really. So there's really no strong feeling one way or another that a biopsy is necessary. If we look at the right, they were asked, is the clinical picture alone enough to make a diagnosis of calciphylaxis? And we're starting to see a little bit more leaning to the right in terms of agreement, but still there are some of the experts who are staunchly in disagreement with that, as we see on the left side. So the diagnosis can be challenging, and as can the treatment be. So let's talk about the treatment. Well, again, there are no randomized controlled trials. At this current moment, there are no evidence-based practice guidelines for this, and frankly, no technically approved treatments for it. And any therapies that we do are all considered off-label. So again, this is expert opinion. Well, in general terms, we want to control their pain. We want to take care of their wounds. We want to modify their risk factors. That also goes with potentially medications. And let's also talk about some of the things that have been done historically and some of the things that could be coming down the road and future directions. So analgesia. Again, severe pain is the hallmark feature, or one of the hallmark features of this. So we really need to make sure that the patients are adequately given analgesia. Now, more often than not, they'll need opioid therapy, sometimes at significantly large doses. The pain is a somatic form of pain. It is felt to be because of tissue ischemia, tissue infarction going on. So it is oftentimes very helpful to get other people involved, pain management, palliative care. This is not just a multimodal type of treatment, but also multidisciplinary. And that's one of the kind of driving points on this, is that we really need to work as a team and get multiple people involved with this. As far as wound care, well, we can do debridements, chemical versus surgical. Generally speaking, the default is more of a chemical debridement, getting rid of necrotic and dead tissue, preventing infection. Surgical debridement can be done on a case-by-case basis. This is one case of a patient who had calciphylaxis who did undergo debridement, then subsequent skin grafting, and we see they actually did quite well after 7 months. Well, risk factor modification. We've already talked a lot about the calcium and the phosphorus, so we want to control both of those things. We want to control secondary hyperparathyroidism. We do have a tighter region of intact PTH that we're aiming for as nephrologists when people have calciphylaxis. And we can use agents like cinacalcet, or otherwise known as Sensipar, or etacalcetide, which is a newer calcimimetic, which is the IV formulation given at dialysis. Surgical parathyroidectomy also in just selected cases. We want to stop offending medications, some we've talked about already, including the calcium, iron. But again, one of the things that Dr. Hix went over is, if possible, we would like to try to minimize exposure to vitamin K antagonists. So if we don't want to use warfarin, well, what are we going to use? Well, apixaban is approved for end-stage renal disease. This is a series of 20 patients who were given apixaban after they were diagnosed with calciphylaxis. Most of them were for atrial fibrillation. And we see that they were followed an average of about 100 days, but some of them close to about 270 days. And we see for these patients, only 5% of them, or 1 or 20, actually had a thrombotic complication. As far as the bleeding, there was 20%, and the 1-year mortality, 20%, which, although maybe doesn't sound good on paper, actually compared to what we know about calciphylaxis and mortality, that's actually not too bad. Let's talk about sodium thiosulfate. That's what we recommend quite a bit. Historically, it was used for cyanide intoxication and has been used in the past to try to treat calcium nephrolithiasis because it's thought to be a calcium chelator. So in 2004, that was the first time it was used, again, with the role of being a calcium chelator and then eventual removal of the calcium through dialysis. The problem is that we're not so sure that's really how it works right now. There are some newer models and postulations, vasodilatory effects, antioxidant properties. These are mediated possibly through increased glutathione or hydrogen sulfide production. An interesting point is that sodium thiosulfate in itself, by giving that in itself, can actually provide significant pain relief for patients also, which lends some support to perhaps this is a vasodilator as well. Well, how do we give it? It's given at dialysis. Sometimes we have patients who are peritoneal patients, or maybe they don't even have end-stage renal disease. We would still recommend giving it as an IV formulation. Previous attempts at using oral or intraperitoneal formulations have not shown success. Given for approximately 3 to 4 weeks as a trial initially, and then if people are showing response, we would continue for essentially until the wounds are healed, but a median is about 3 months. I'm going to review 2 of the studies that are most often cited for the evidence for sodium thiosulfate. This looked at all dialysis patients who received sodium thiosulfate at a Fresenius dialysis unit over about a year. And then they sent a survey to the treating nephrologist asking them the questions, well, how did the patient show up and how did the patient do? And then they looked at mortality data as well. Of the patients who had a nephrologist that responded to the survey, 70% of them showed improvement, and 26% of them, in fact, showing complete resolution. Now, of course, one of the big problems of doing a study like this is it's going to introduce an extreme amount of bias because it depends on whether or not the nephrologist chose to submit a completed survey. And we see in the Kaplan-Meier survival curve here that the solid line is the patients who had completed surveys, and they had better survival compared to the patients who did not have a survey completed for them. This was a retrospective review in Austria of 27 patients with calciphylaxis. They looked at all-cause mortality, remission, and amputation rates. This one's a little bit tough to interpret, but they did see that of the 27 patients, approximately 48% of them survived. And if we look in the middle series of bars, those are the survivors. 85% of them actually showed clinical remission, whereas on the far right, we show the non-survivors significantly less remission. It's a little bit difficult to say that sodium thiosulfate played a role in that, but this is the data that they showed. Sodium thiosulfate can oftentimes cause a severe acidosis, the reasons of which are not clear, but it can be limiting in terms of the treatment, as can the nausea and vomiting. We've actually had more than a couple of patients we had to stop treatment on because they just had intractable nausea. Well, what are other therapies? For our peritoneal dialysis patients, we do generally convert them to hemodialysis because there is some literature to suggest better wound healing. There is some literature for bisphosphonate therapy, but again, it's questionable. Perhaps one might consider it in a hypercalcemic patient. also hyperbaric oxygen, but that is a significant commitment, 90-minute treatments for upwards of 3 weeks daily, and with unclear evidence. So these are some of the other postulated therapies for future or that are looked at now. I'd like to go to the bottom one, kidney transplantation. There are case reports of transplantation in itself leading to healing of the lesions. In fact, in Norway, interestingly, having calciphylaxis moves a person up on the transplant priority list. So this was a meta-analysis looking at all the data that we have so far, just published this year, looking at these 5 things that I mentioned, sodium thiosulfate, parathyroidectomy, etc. And they were looking at outcomes, amputation, worsening lesions, and death. For sodium thiosulfate, unfortunately, what it showed was there was no difference at all in terms of amputation, worsening lesions, or death. For surgical parathyroidectomy, there was perhaps a slight improvement for worsening of wound deterioration, but it also is worth mentioning that the patients who had parathyroidectomy were younger and had a higher serum albumin, suggestive perhaps better nutritional status or better health at baseline. No difference for cinacalcet, no difference for hyperbaric oxygen or bisphosphonates. So where does that leave us now? Well, there are trials going on looking at sodium thiosulfate. There are trials looking at vitamin K, and also this agent SNF472, which is a form of phytate. Phytate being an agent that is naturally occurring in a lot of food, but it is felt that patients may have phytate deficiency, and this agent actually inhibits hydroxyapatite crystals and inhibits vascular calcification. Let's go back to the experts. So what are they saying about treatment? Okay. Well, the table on the left is sodium thiosulfate a first-line treatment option? It's fairly across the board, perhaps a little bit of leaning towards the agreement, but again, it's really not clear. There on the right, that's looking at parathyroidectomy or cinacalcet. Again, that's pretty much across the board, no consistency. They do agree on the right that vitamin K or stopping vitamin K antagonists should be considered. They also strongly agreed that the treatment should be multimodal. And unfortunately, they strongly agreed on the right that the prognosis of calciphylaxis is poor. So to summarize, the diagnosis can be quite vexing, a challenge. We've looked at a couple different ways that we can perhaps make that diagnosis. We've looked at some of the treatment options we have out there, but as we've said, there's really not very good data for any of these modalities. Hopefully there will be things coming down the road. So when we're left in this situation of calciphylaxis, we hope to soon, one day, be having a better picture. Yeah, thank you. Some questions?
Yeah, very simple question. What do they actually die of?
Oh, yes, actually they die of sepsis, the infection. Yeah.
Great presentation.
Thank
So I have a question. Is there a way to identify patients at risk other than the end-stage renal disease on whom care should be taken in starting or continuing warfarin?
I don't know if there's any model that can kind of stratify risks. Specific to warfarin, you're saying? Are you asking, should an end-stage renal patient be started on warfarin or other than end-stage renal disease? Well, that's the minority of the cases. That's not really clear either. I don't know if Dr. Hix has any other input on that.
The mysterious way that sodium thiosulfate might work, do we know if it upregulates glycoprotein or the carboxylation?
From what I came across, I don't believe that there was actually an interplay with that. More the vasodilatory properties and the antioxidant.
So is there any pattern to where the lesions occur, such that one could advise patients who are at risk would advise. So in other words, a pattern on the work may suggest a certain type of behavior or something that we could advise them to avoid.
You know, that's also a pretty tough one. In earlier on, there were postulations that, you know, trauma, so, you know, needles, any type of local trauma could perhaps propagate a calciphylaxis to start, but even that is starting to get into a question if that really happens, so it's really not clear.
The patient was presented today was an atrial fibrillation on dialysis on warfarin. And in fact, there's no plain reason to believe that warfarin is a benefit to those patients. The other question is, would novel oral agents be any better in atrial fibrillation and dialysis?
So there is, I know, outside of calciphylaxis, there's already an area of debate whether or not warfarin anticoagulation is beneficial for end-stage renal patients. I do think it has to be looked at a case-by-case basis. You know, oftentimes when patients are on warfarin, we will also discuss with the cardiologist to discuss the risk benefits. I think that we do see the literature supports there is increased risk for bleeding as well, and not clear if there is benefit for anti-thrombotic effects. So I'm not sure if that answers your question.
I guess the second part of the question is there any evidence that the novel agents are any better?
That's a good question. I don't know if perhaps I'm not aware of that literature. I mean, it doesn't have the vitamin K effects, but I think perhaps the agents are still new enough that maybe we don't have enough of an incidence of the disease to really have a great idea. But I would say theoretically they may be better, but I can't say for sure that the data is there. Yeah. Okay, thank you.